Good evening, doctors. On behalf of Alembic Pharmaceuticals, I welcome you all to today's webinar. Alembic always believes in facilitating knowledge transfer, and towards that, today we have the privilege of interacting with the faculty who will guide us on how to translate clinical data into real-world practice. These insights will have a great relevance in the Indian scenario. Without further ado, may I invite Alembic's Senior Vice President of Medical Services, Dr. D.A. Khanke, to take the event forward and introduce the moderator of the webinar. Over to Dr. Khanke.
Thank you, Vishal. Thank you so much for the invite. So it gives me great pleasure to introduce the moderator for today's session, which is Dr. Tiny Nair. Dr. Tiny Nair is an experienced cardiologist from Trivandrum and is the head and chief consultant in cardiology at PRS Hospital. His department of cardiology undertakes complete invasive and non-invasive workup and intervention cardiology techniques and is well equipped with the state-of-art cath labs and 3D echo. He is also the Joint Secretary, Indian Society of Hypertension. Dr. Nair has more than 50 publications to his credit and is on the editorial board of Hypertension Journal, Indian Heart Journal, Kerala Heart Journal, and also the prestigious European Journal of Heart Failure, the Indian edition. Dr. Nair has been recipient of Best Doctor Award, Government of Kerala, and also the Most Inspiring Doctor, Economic Times 2019. So with this introduction, I would now request Dr. Nair to please take today's proceedings forward. Dr. Nair, sir, to you.
Thank you, Dr. Vishal, and thank you, Dr. Khanke, for that introduction. I think welcome all to this very important webinar today. I think we all understand the last decade, introduction of NOACs has been a truly game changer in the science of thrombosis. Now, if we take, for example, arterial thrombus, we are talking about atrial fibrillation and stroke prevention. Okay, NOACs have shown that they are certainly better than standard warfarin anticoagulation, vitamin K antagonists. Take venous thromboembolism. For example, take VTE or a pulmonary embolism or a DVT. Prevention of DVT or pulmonary embolism, or even treatment of pulmonary embolism and DVT, today NOACs tend to replace at least partially the vitamin K antagonists. But then the COMPASS trial did something unique. It brought about an entire new concept of vascular protection by a very low dose of a NOAC, which is Rivaroxaban. We all today know for the last couple of years, people have been using dabigatran, Rivaroxaban, and apixaban for arterial venous thrombus. But this is a sea change from the very concept of prevention of thrombosis, whereby we're talking about vascular protection. We're talking about polyvascular disease, high-risk subsets, where adding a small dose of Rivaroxaban to an antiplatelet can prevent cardiovascular events. And that has been a total new concept. And to talk about that today, whom do we have? We have the real person who did COMPASS, the principal investigator of COMPASS, Dr. John Eichelbaum. Dr. John Eichelbaum is the professor of medicine at the CV is there on the screen, at the McMaster University Population and Health Research Institute, at Hamilton General Hospital at Ontario, Canada. He is very renowned, right? Whoever is in the science of thrombosis knows Dr. John Eichelbaum by his name. He has 600 published papers. 600 published papers. He is rated as the top 1% of those cited research globally. Okay, right. He's of the PI of COMPASS. And very recently, if you keep track, just about 3 days back, we saw his new article in JAMA that talks about symptomatic lower extremity PAD. And I'm sure that Dr. Eichelbaum will touch upon that and give us his new insights. So with that, I would request Dr. John Eichelbaum to take over the stage and talk to us. The flow is like this, Dr. John talks to us for about 30-35 minutes. And meanwhile, you can put your questions in the chat box so that we can get the maximum knowledge out of Dr. Eichelbaum in the science of thrombosis. Dr. Eichelbaum, please.
Well, thank you very much, Dr. Nair, and good evening, friends and colleagues in India. I would almost prefer to talk about cricket tonight because it's been such a great test series, but I know I have to talk medicine and science. Well, let's face it, this is my second passion. And as Dr. Nair has just told us, we've got some spectacular new data from Rivaroxaban for long-term secondary prevention in arterial vascular disease. Well, I will talk, as mentioned, for about 30 to 35 minutes, and I hope you will flood this environment with questions and comments because we want to hear from you. We want to get your interaction on these topics. I have commercial relationships. I've received honoraria and research support from many companies, indeed from every company that markets the DOACs or the NOACs. My agenda, very briefly, I want to start by touching on the burden of arterial and venous thrombosis. This will be brief. I want to remind you of the incredible advantages of the DOACs, but also some unmet needs. I will not discuss atrial fibrillation in any detail. A couple of slides to set the tone, and then focus most of my attention on low-dose Rivaroxaban for arterial vascular protection. And I will end with a slide to say, well, not all the issues have been solved. We still have work to do. Let me start by addressing the burden of disease. And one could argue I don't need to remind you of that burden because it is self-evident. But every time I look at this, I find it very sobering to recognize that 1 to 2 per 1,000 population will experience venous thromboembolism each year. And of course, venous thromboembolism is a chronic condition. So every year we add 1 person per 1,000 with venous disease. Every 10 years, and on average, people with venous disease will survive at least 10 years. So that's 10 per 1,000 or 1%. So venous disease, very common. Atrial fibrillation, even more common, 1 to 2% of the population. So collectively, we're talking 2 to 3% of the population. And then arterial vascular disease, 2.5%. 1 in 40 persons has arterial vascular disease. This is an incredible problem in terms of its scope, its magnitude, the burden of suffering due to morbidity and mortality. So we've got a lot of work to do to reduce that risk. The good news is we have excellent tools, but sadly we don't use them as well as we can. 2021 brings new possibilities in India because now you have drugs such as Rivaroxaban, which are not only highly studied, which are not only incredibly effective, but are now affordable for a much broader range of the population. So atrial fibrillation, and as I said, this won't be my major focus, but I want to remind you, not only 1 to 2% of the population, it's a growing problem. 1 in 20 patients with atrial fibrillation experiences stroke each year. This is hundreds of thousands of strokes in India, and 1/3 of all strokes in older patients, in our parents, 1/3 of all strokes are atrial fibrillation. This stroke is preventable, but you, like almost every country on earth, undertreat people with atrial fibrillation. Cardiovascular disease, an estimated 50 million people affected in India. Incredible numbers. This is more than the population of Canada, more than the population of my home country, Australia. this many people with cardiovascular disease means millions of deaths, which means millions of patients with disability in the community. A growing problem and also undertreated. I could spend the rest of the session talking about undertreatment, but I want to move on now and talk about where anticoagulation works and where the DOACs fit in. The good news is that oral anticoagulation used long-term is incredibly effective to protect against recurrent venous thrombosis, is stunningly effective in reducing the risk of stroke in atrial fibrillation. And with the advent of Rivaroxaban at low dose, for the first time with antithrombotic therapy long-term, we can reduce not only morbidity, but we have a big impact on mortality. More of that shortly. Now, those of you who graduated as long ago as I did, back in the late 80s and in the 90s, will remember that there was a time when the only anticoagulant we had was heparin and warfarin. And indeed, vitamin K antagonists are effective. In atrial fibrillation, they reduce stroke by 2/3 and death by 1/4. But obviously, they only work if A, we use them, and B, we control their anticoagulant efficacy with careful monitoring. Atrial fibrillation is undertreated around the world. This is India, 40%. I suspect this is an overestimate because these data come from highly committed centers. If we take the entire population, it's probably even lower than 40%. It's probably 20%. The issue, of course, in India is it's one thing to have incredibly well-trained physicians, as I know Indian physicians are incredibly well-trained, but it's another matter to have the infrastructure throughout such a vast populated country that can provide high-quality INR monitoring. It's a very expensive undertaking, and I can understand one of the reasons for underuse in India is it's really tough to monitor warfarin or acenocumarol. Undertreatment, I showed you the data from the Garfield International Registry. Here I show you some local data. You are undertreating atrial fibrillation. According to this particular Indian publication, and I apologize that the publication name doesn't appear at the bottom, but I can get that for you. It may be actually be on my next slide. We can see that only about 1/3 to 1/2 in this particular study, this Indian study, of patients with high-risk atrial fibrillation are treated. Not only that, when they are treated, only 1 in 3 of INRs are in the range. So we've got a big, big problem. This is where the DOACs truly come to the fore as a desperately needed, an incredibly convenient, effective, and safe therapy. Direct oral anticoagulants, you know them, Rivaroxaban, apixaban, and dabigatran. In some countries, there's also edoxaban and betrixaban, and this is not the last of the DOACs because second-generation DOACs are coming. Why are they coming? Because DOACs have such important advantages. They work fast. They have a low potential for food and drug interaction. They do not need sophisticated monitoring. They are predictable in their anticoagulant effect. Their treatment regimens are simple. As a consequence, it's easy to use them. Patients love them. And to top it all off, they're safer than warfarin, and they're at least as effective or more effective. So what's been happening in India with DOACs? and this again comes from the Garfield Registry. This is 2018 publication. You've seen in the red and the orange that the proportion of patients with atrial fibrillation in India over the past decade who are treated with a DOAC has barely risen. And there's a good reason for that, because these drugs, when they're still in their originally marketed form, are expensive. But that's changed because the DOACs, and Rivaroxaban in particular, is now available at a very affordable price. So I've set the scene about the burden of disease and the incredible opportunity, but also challenge to you, my Indian colleagues, to use DOACs safely and effectively in your population. So what about DOACs in atrial fibrillation? And I want to remind you that the drug that we're talking about here, Rivaroxaban, is perhaps the most comprehensive representation of DOACs for thromboembolism prevention and treatment. It is by itself the single most extensively evaluated DOAC. It is the single most widely approved DOAC around the world. It has the most indications, and it's now widely available in your country at an affordable price. It's approved in many countries for venous thrombosis prevention in surgical patients, in medical patients. It's approved for initial and long-term prevention of PE and DVT, of stroke prevention in atrial fibrillation, including patients having cardioversion, ablation, or stenting. It's being tested in pediatric indications. It's approved in many countries for acute coronary syndrome, and the key highlight of my talk today, in chronic arterial vascular disease. There is no DOAC that has this portfolio of indications around the world. So focusing on stroke prevention in atrial fibrillation, I've already mentioned how incredibly effective the DOACs are. This is to remind you, the trials in atrial fibrillation, you see Rivaroxaban, dabigatran, edoxaban, and apixaban, all highly effective, all safer than warfarin, with less intracranial bleeding and less fatal bleeding. I'm not going to talk any more than that about atrial fibrillation, but again, there is a vast array of high-quality evidence supporting the use of these agents in atrial fibrillation. There is one point that I want to make that escapes most of us because we look at all the other data, but we fail to recognize, we forget that not only do DOACs provide protection against thromboembolism in a safe, effective, and convenient manner, but they also provide renal protection. And what do I mean by that? Well, in the randomized trials, patients who are randomized to a DOAC compared with a vitamin K antagonist had less rapid deterioration of renal function. And here we have it. In fact, the signal with apixaban was not that evident. It may or may not provide the same protection. With dabigatran, here we have warfarin's deterioration over time, less so with dabigatran. And Rivaroxaban, here is warfarin's deterioration over time in renal function, less so with Rivaroxaban. You don't really need another reason to choose a DOAC, but here is yet another good reason. Let me turn to the main part of my talk, and the main part will be this focus on the role of Rivaroxaban in chronic coronary or peripheral artery disease. Now, you will notice that it's a 40% risk reduction when you add Rivaroxaban to aspirin. Now, don't be misled by comparing that with this 80% risk reduction, because you would be forgiven for saying, well, that's pretty modest compared with atrial fibrillation. I will show you separately how we should be looking at this magnitude of benefit, because it's a very large treatment effect. More on that in a moment. I also don't want you to think that I'm saying that antithrombotic therapy is the only therapy that you should be interested in for long-term secondary prevention. Of course, to the contrary, lifestyle changes are fundamental, and there are many other risk-modifying therapies, including lipid-lowering, blood pressure-lowering, glucose-lowering, ACE inhibition, and more recently, anti-inflammatory therapy. However, the focus today is on antithrombotic therapy, and I want to remind you that 95% plus of all acute myocardial infarction, of all acute ischemic stroke, of all acute limb ischemia is mediated ultimately by thrombus formation that blocks blood flow and results in distal tissue ischemia. So, at least theoretically, modulating coagulation and platelet activation should be able to prevent many of these events. We've had aspirin for many years. It works, modestly so, but it works. Clopidogrel, not really better than aspirin. Capri, a small benefit. No mortality benefit over aspirin. The combination, no mortality benefit compared with aspirin. The combination of aspirin and ticagrelor, post-coronary stenting after a year, no mortality benefit compared with aspirin. You will see, as we look at the Rivaroxaban data, when you add Rivaroxaban to aspirin, not only do you prevent non-fatal cardiovascular events, but you provide a clear mortality benefit. We're going to talk about the COMPASS trial, but remember that the COMPASS trial is one of no less than 4 trials that have shown that low-dose Rivaroxaban added to antiplatelet therapy prevents morbidity and saves lives. I won't talk about the other trials, but I want to remind you that the first of these was the Atlas TIMI 46 trial. That was followed by the Atlas TIMI 51 trial of 15,000 patients. The most recent of these trials was the Voyager trial. The Atlas trial, of course, was in patients with a recent acute coronary syndrome, a mortality benefit. The Voyager trial was in patients with peripheral artery disease and recent revascularization, another 6,000 patients. And the COMPASS trial was 27,000 patients. Collectively, we have data on more than 50,000 patients treated in randomized trials testing low-dose Rivaroxaban. We have an enormous body of evidence. So what I tell you from COMPASS is externally supported by at least 2 other mega trials. Now, here are the data for the COMPASS trial. It's patients with chronic coronary or peripheral artery disease, allocated treatment with aspirin, with Rivaroxaban alone, and with Rivaroxaban plus aspirin. Rivaroxaban alone was not effective. It looks promising here, but this was not significant. So I won't speak about this in any detail, but I will speak in detail about the comparison between aspirin and Rivaroxaban plus aspirin. Here is the study design: chronic coronary or peripheral artery disease, 3 arms as mentioned. We expected to follow patients for 3 to 4 years, but after just 2 years of median follow-up, the Data Safety Monitoring Board recommended that we stop the antithrombotic arms of the trial. Why? They felt that it was no longer ethical to continue. The benefits of Rivaroxaban plus aspirin were so great. We had to get this treatment to patients. This is also something that we often forget, because now, 3 years later, I'm explaining to you the efficacy and the safety of this regimen. Remember that 3 years ago, this signal was deemed to be so compelling that it was no longer ethical to continue randomized treatment. We had to make this available to patients as soon as possible. Now, remember that people who entered the COMPASS trial were already well treated. 90% were on lipid lowering, 70% on ACE-ARB, 70% on a beta blocker, and almost 90% on aspirin before the trial started. If you saw a patient in your clinic on these therapies, and if they were apparently stable, you would probably say, this one, he, she, they're in good shape, no additional treatment required. Well, when we randomized them to treatment with low-dose Rivaroxaban, we reduced the composite of MI, stroke, and CV death by a quarter. That is an additional quarter risk reduction, having already achieved a 19% risk reduction with aspirin. And that's where we get to our 40%. We have 19% relative risk reduction with aspirin, antithrombotic trialist collaboration, Lancet 2009. And now we're adding to that, over and above, a 24% risk reduction. Please be reminded that in patients who predominantly had coronary or peripheral artery disease, the benefits were not just a reduction in MI, but there was also a reduction in stroke. And the reduction in stroke was unprecedented, a 42% reduction in all-cause stroke, a 49% reduction in ischemic stroke. There's another point to remember here. Although these patients, the majority of these patients, did not have a history of stroke, yet for every 3 myocardial infarctions in the control group, there were 2 strokes. Think about that for a moment. When you see your patients and they've had MI a year ago, 2 years ago, and you're focusing on secondary prevention, as a cardiologist, naturally your focus will be on preventing recurrent MI. But if you talk to your patient, I will hazard a guess that they will be more interested in the stroke story than the MI story, because stroke causes disability of a degree that most patients, that many patients will think is worse than death. By adding Rivaroxaban to aspirin, you will reduce that stroke risk more than with any other treatment available at your disposal, including blood pressure lowering, including statins, including ACE inhibition, including aspirin. Rivaroxaban, the single most effective therapy for this indication. Here is the effect on ischemic stroke, a 49% risk reduction. Truly a staggering treatment effect. For this reason alone, this is a compelling therapy. Indeed, we have many reasons why this is compelling. I want to digress for a moment and ask you, if you were to interview your patients with vascular disease and ask them about the events they fear the most, the events that they would most like to be protected against, I'm guessing that on top of that list might just be stroke. Now, if you're talking to a population of patients with cerebrovascular or coronary or peripheral artery disease, and if you listed down all of the possible complications, I'd suggest that right up there, perhaps second, perhaps even first, would be amputation. And if your patient did not have stroke and did not have amputation, perhaps the third would be mortality, being alive. Now, if they'd had stroke or amputation, they might prefer to be dead. Remember that in COMPASS, this trifecta of effects, stroke, amputation, and mortality, were each reduced. For the first time ever, the COMPASS trial showed that with one simple add-on therapy, Rivaroxaban, widely available, inexpensive, we achieved the trifecta of reducing the three of the most feared complications of vascular disease. Let's take a brief look at the peripheral limb benefits. And here are the outcomes that we measured in COMPASS. Now, Dr. Nair told us about the JAMA paper. I had some slides on that, but there's so much to cover, I have to regretfully bypass that study. But I'll give you the big picture outcome. In peripheral artery disease, we reduced amputation, we reduced acute limb ischemia, and we reduced chronic limb ischemia. The reduction in amputation was over 50%. You can cut ischemic stroke by almost 50%. You can cut amputation by about 50%. And you can reduce mortality by 18%. So where is the catch? You must say, nothing's perfect in medicine. There must be a downside. Well, you're right. There is a bleeding risk. Here are the bleeding data. On the right is the conventional definition of ISTH major bleeding. Here is the primary outcome in COMPASS, a slightly more liberal definition, and therefore the event rates are slightly higher. Three messages. First, Rivaroxaban plus aspirin in blue is associated with more bleeding than aspirin. Message two, the absolute excess of bleeding is only about a 0.3 or 0.4% per year on average, a very small absolute increase in bleeding. 0.3, almost all of the excess bleeding is GI and happens in the first year. No excess of fatal or intracranial bleeding. What does that mean? It means that in the first year, the number of ischemic events prevented outweighs bleeds. But because there is no further excess of bleeding, the net benefit is much greater in the second year. And by the third year, it is even greater. The benefits of Rivaroxaban plus aspirin, the net benefits, emerge early and continue to accrue, continue to increase over time. So let me provide you with some context. We have a number of routinely used secondary prevention therapies, and we have several new therapies or newer therapies. Here we have the addition of Rivaroxaban to aspirin in people receiving lipid lowering, blood pressure lowering, and ACE inhibition. We have an additional 24% relative risk reduction. That's on top of the other therapies, and the magnitude of benefit is in the same order as statins, blood pressure lowering, and ACE inhibition. We have an 18% reduction in mortality. Remember that the average effect of statins is only a 9% reduction in mortality, and this is over and above the effect of statins. It's over and above the effect of blood pressure lowering and ACE inhibition. And stroke down by 42% is a greater treatment effect than any other therapy that you can access for secondary prevention. In terms of antithrombotic therapy, the treatment effect on MACE is larger than for any other therapy, and the mortality benefit. This is the first long-term antithrombotic regimen since aspirin that saves lives. Not significant for clopidogrel, not significant for aspirin plus clopidogrel, not significant for aspirin plus ticagrelor, but an 18% mortality reduction. So who to treat? In my last 2 minutes, who to treat? It's clear who we ought to treat in patients with cardiovascular disease using the COMPASS regimen. We could treat all types of patients, but if we focus on our highest risk patients, we get increasing magnitude of benefit. Patients who have disease in 2 vascular beds, patients who also have heart failure, patients who also have renal impairment, patients who also have diabetes. These are the high-risk groups, and they will achieve the largest absolute benefits in terms of reductions in major adverse cardiovascular events and mortality. I'm going to go to my last slide and summarize the message, and I'd be pleased to come back to any of these points in the discussion. But let me summarize, Chairperson, ladies and gentlemen. I've shown you the story of thromboembolism, the burden that it represents worldwide. I've shown you the incredible potential for DOACs across a spectrum of thrombosis, venous thrombosis, cardiac thromboembolism, and arterial thromboembolism. Specifically, in patients with chronic coronary artery disease, because you're cardiologists, and that's why I focus my talk, my conclusions on chronic coronary disease. If you, tomorrow morning, add low-dose Rivaroxaban to aspirin in your patient with chronic coronary disease, or indeed chronic peripheral artery disease, or both, you will see a 1/4 reduction in MACE. You will see a 50% reduction in ischemic stroke and amputation. You will see a 1/5 reduction in mortality. The net benefits start immediately and continue to accrue over the long term. And patients who derive the greatest benefits are those with polyvascular disease, those who also have mild or moderate heart failure, chronic kidney disease, or diabetes. This makes the dual pathway therapy option a highly attractive option for long-term management of patients with chronic coronary disease. And with that, I'm going to stop my presentation. I thank you for your attention. Please send in questions, and I will hand back over to the chair.
Thank you, Dr. Eichelbaum. That was a really, truly excellent lecture, and it covered kind of everything that you wanted to convey. And, by the time you were perhaps halfway through your lecture, I could see a lot of questions coming in, and all pertaining to Rivaroxaban, not cricket, anyway. And of course, a couple of things that people have been consistently asking is, one is about the timing of giving Rivaroxaban, because this is a vascular dose that has been given twice a day. And we generally know that Rivaroxaban is better absorbed if given with food. So a couple of questions came in as to how should we advise the patient regarding food intake, and what should be the normal morning dosage time? What was your experience with all those patients in Compass?
Terrific question. And it gives me the opportunity to clarify. Rivaroxaban 2.5 milligrams does not have to be taken with food. It can be taken on an empty stomach. It can be taken with food. It can be taken without food. It doesn't matter. Now, why is that? It's only with the 15 and the 20 milligram dose that absorption is food dependent. But at low doses, it's independent. Now, we normally give it twice a day. It's not critical to give it exactly every 12 hours. I tell my patients breakfast and dinner, but you could go 8 and 8 if you so wish. You could take it before bedtime, and when you wake up in the morning, it's flexible. It's not critical. Anytime 10 to 14 hours is fine.
Yeah. Now, the other question that has come in is that what about people who are very elderly? When people come above the age of, let's say, 80s, and still they fulfill the criteria of what you had in Compass, is it safe enough to put them on dual pathway inhibition in addition to an antiplatelet?
So what we've learned from the trials, and this is not just from Compass, but also from atrial fibrillation, is the higher the risk, the greater the net benefit. So both bleeding and thrombotic events will increase in higher risk patients, but the net benefit is greatest in those at highest risk. And this includes older patients who frequently have comorbidities. The bottom line is I would not deprive an older person. My mother is 90, my father is 88. I would not deprive them of the benefits of these therapies purely because they're older. In fact, on the contrary, if they are at high risk because of age and other factors, they'll likely get a greater benefit.
Yeah, I think that's very important to learn, for the audience down here, that age is not something that we deny our treatment, whether it is intervention, whether it is antiplatelet therapy, but we should know that every antithrombotic, as we add up, do increase the chance of bleeding, as Dr. Eichelbaum has clearly shown. But fortunately, with the vascular dose of rivaroxaban, the increase in bleeding is mainly GI. And second thing, there's no increase in fatal bleed or intracranial bleed, so it is perhaps manageable. Now, with that, we have two questions that has come up, and both the listeners have asked that if there is a bleeding, let's suppose there's a bleeding, how do I approach it? Perhaps they're trying to say that we have something for dabigatran, for AFib if they bleed. Do we have an antidote for rivaroxaban, and do we really need it?
All right. Well, a very important question for several reasons. The first reason it's important is we know that Indian physicians are the same as Canadian physicians or US physicians or European physicians. We all hate bleeding because we think that if someone has a stroke, that is an act of God. And you've heard this before, but it's worth repeating. If someone has a bleed, it's my fault. And my patients don't see the strokes that we prevent. They only see the bleeds that we cause, so to speak. So it's incredibly important to get the understanding right. For Compass, firstly, the excess of bleed was very small. Secondly, managing the bleeds, we never had reversal agents in Compass, and we never saw an excess of fatal bleeding. Thirdly, the dose of rivaroxaban in Compass, the daily dose is half the prophylactic dose of rivaroxaban in the trials. This is 5 milligrams a day. Remember, in atrial fibrillation, we use 15 or 20. Remember, in primary prevention of VTE, in orthopedic or medical patients or COVID patients, people are using 10 milligrams once a day. We've got half the dose. So we don't need to reverse because these are very low levels. Finally, for those of you who like to have the reassurance in the back of your mind, we know from multiple studies that using a prothrombin complex concentrate, a blood product, not a cheap blood product, but certainly a lot cheaper than reversal agents. These blood products can also help to restore hemostasis in people on DOACs. And that's really more for atrial fibrillation, but if you need the reassurance, it also exists for COMPASS type patients.
Yeah, one of the questions from one from Dr. Vyas from Jhansi. He has asked that what about diabetic patients? So would you use that question to basically highlight as to what subset of patients would you choose? See, despite all that, even with the price reduction, Rivaroxaban is costly. And in Indian patients, we have about 80% of patients are not covered by insurance, medical insurance. They have to fund it from their own pocket. And over time, it becomes expensive. So what subset in the background of Indian background, and this question is also by Dr. A.K. Pancholia, he has also asked the same question. This flavor is same. In Indian subset, what would be a choice of a subset where you would say, okay, Indian doctors, this is somewhere where do not forget adding up Rivaroxaban.
Yeah. No, and very good question. And I don't mean to be flippant in saying it's cheap. I realize that if you don't have money, it can't be cheap. If you can't pay for it, it's not cheap. And I also am every time awed and humbled by the fact that in India, there are more wealthy people than there are people living in Canada and Australia combined, because you have, even if 10-20% of your population is very wealthy, that's far more people than live in my country. Having said that, I completely endorse the use of Rivaroxaban in those at highest risk. I didn't spend a lot of time talking about this, but the highest risk patient is a patient who has polyvascular disease. That is disease in more than one vascular bed, a prior coronary event and peripheral artery disease, a prior coronary event and cerebrovascular disease. That's number one. They should, in my opinion, all be treated unless they have a contraindication. The next highest risk groups, they come in a pack of 3: mild or moderate heart failure, diabetes, and chronic kidney disease. So they are the next 3 groups of highest risk people who would benefit from the COMPASS regimen more so than the rest. We've published more than 40 papers on COMPASS, and I know you highlighted the PAD paper, but Deepak Bhatt has published the diabetes paper in Circulation. Keith Fox has published the kidney disease paper in JACC, and Kelly Branch has published the heart failure paper in Circulation. Each of these papers highlights the large benefits in these 3 high-risk subgroups.
Yeah, but then, we know that the Commander trial, Commander HF, showed that the benefit in heart failure, when you consider entire heart failure, was kind of borderline. So whenever we go and speak about Rivaroxaban in a session, we are asked with this question that how would you explain Commander heart failure and put it side by side onto COMPASS, and what would be your take on that when it comes to patients who have, because today with extensive availability of echocardiogram in India, we see that patients come with an LV dysfunction, right?
Yeah.
So does an LV dysfunction enable me to write Rivaroxaban for my patient?
Okay. It's a great question. And again, if I had time, I've got a whole slide set on this. But let me summarize very briefly. Heart failure in Commander was recent acute decompensated heart failure in patients with LV dysfunction, class 3 or 4, New York Heart Association, or reduced left ventricular ejection fraction. Heart failure in COMPASS was mild or moderate heart failure. So 2 different types of disease. If you have recent acute decompensated heart failure, Rivaroxaban is not going to stop you dying from arrhythmias or pump failure. At the same time, if you look at the Commander heart failure papers in JAMA last year, there was a very elegant paper that showed that the reduction in thrombotic events in commander heart failure was exactly the same as the reduction in thrombotic events in COMPASS. Completely coherent story. So it does work in heart failure. The problem is in decompensated heart failure. Patients are dying from pump failure and arrhythmias. And that's where the biggest problem is for such patients.
Yeah, I think that's very important to realize that, if you're targeting pure heart failure, obviously it doesn't have an effect, because decompensated acute heart failure is a different ballgame altogether. But when you have your vascular patient within left ventricular dysfunction, this molecule is far more efficient in preventing long-term morbidity compared to a single or dual antiplatelet agent. So one common question that has come in, I mean, it might look very trivial to you, because people have said that, for example, DVT or PE, we have a timeline as to how long to give Rivaroxaban, or for that matter, any drug, right? But then for this vascular dose, do we have a timeline? How long do we give? Couple of questions there. How long do we continue a vascular dose of Rivaroxaban? Do we say that lifelong? Or,
yeah. So
so
great question. Now, I want to remind folks, though, that VTE is also a chronic condition. It's just that we can usually handle a recurrent DVT or a recurrent PE. The story of optimal duration of anticoagulation, and I saw a question in the chat in front of me as well about this. There's too much to talk about, but it's a great story. I'd love to talk about it some other time. The dose of Rivaroxaban in DVT PE is going to be different to the COMPASS regimen, because it's 20 milligrams once a day and then 10 milligrams once a day. In COMPASS, it's 2.5 twice a day. But in COMPASS, we're going to treat lifelong. In the same way that we use a statin, we treat lifelong. We use blood pressure lowering, we treat lifelong. ACE inhibition, aspirin is lifelong. And Rivaroxaban plus aspirin is lifelong. And why wouldn't we? Because the benefits continue to accrue. Year 1, year 2, year 3. We went out to 4 years in COMPASS, and the benefits simply continue to accrue, including mortality benefit. Now, can I add one other point? Some people say to me, well, if 2.5 twice a day is working, can we give 5 milligrams once a day? And the answer is absolutely no. We cannot do this, because we need a low level over 24 hours. That's why we gave a low dose twice a day. We're not trying to get a peak and then a trough and a peak. For arterial vascular disease, biologically, we want to give a low level of a drug over a 24-hour period.
Yeah, that is exactly one question that has popped up here. Can we give 5 milligrams once a day? So it is very clear that we won't give 5 milligrams once a day, and we would rather give low dose twice a day to balance off the uniform suppression of thrombin. Now, that brings us to a couple of questions that has come in, and obviously this is a time of COVID-19. A couple of people have said that, does this 2.5 milligram BID have a benefit on prevention of COVID endothelial dysfunction? Because, there is no guideline, and we have seen centers which write 5 milligram BID of apixaban. There are centers who continue to give 10 milligram Rivaroxaban. There are people who give 15 milligrams of Rivaroxaban, and the duration spans from 1 week till about 6 weeks post-discharge. So what would you do? It's more of a clinical question rather than, we know that there's no guideline, but what would you do in your COVID patient?
Yeah.
A person who has got a lot of D-dimer and
So I'm going to first give you very briefly some new data that you may be familiar with, and then second, I'll tell you my approach. The first part is, we all believed around the world that treating or preventing thrombosis in COVID is necessary, and therefore many countries and many hospitals and many physicians have started using therapeutic anticoagulation in hospital. The NIH active attack and remap cap studies in ICU patients testing therapeutic anticoagulation have been stopped in the past couple of weeks because anticoagulation doesn't work and it's probably harmful. in ICU patients, in our sickest COVID patients with high D dimers, using therapeutic heparin was useless. And to me, this is a very powerful reminder that we may have very strong views about what we think is going to work, but we have to do the experiment to prove it. Because if we just start treating people without the experiment, we start to use processes that may be useless. With that very sobering reminder, what do I do with my COVID patients? Well, in hospital, we give prophylaxis. We do not give routine therapeutic anticoagulation. By the time they leave hospital and they're recovering, we do not treat them with antithrombotics at all. Now, I'm not saying it's wrong to do it, but there is no evidence supporting its use. What I do try to do is put them in a trial. So whilst I don't routinely treat the patient, and I know many of you do, I try to put them in our own anti-coronavirus therapy trial where we're testing Rivaroxaban 2.5 twice a day plus aspirin. Because I think that that is theoretically the ideal combination. Rivaroxaban in COMPASS not only prevented arterial events, not only reduced stroke and amputation, not only saved lives, but it reduced venous thrombosis by 40%. So if you're going to use something, I'd argue the COMPASS regimen would be the best regimen, but try to put patients in trials. If you want to treat outside of trials, I would treat for a month in the sickest patients. That's my approach.
Okay, so let me reconfirm what you said, which means there is no clear data that the hospitalized intensive care sickest patient of COVID benefits by an anticoagulation, be it heparin or low molecular weight heparin, right?
That is correct. In fact, the trial that was stopped early, this is just in the last couple of weeks, we don't have the final data, but there is a suggestion of net harm of using therapeutic anticoagulation. This is low molecular weight heparin, therapeutic anticoagulation in ICU. So the trial was stopped. They're still testing it in the non-ICU patient, but in the ICU patient, it looks like it's going to cause harm because it causes bleeding, doesn't save lives, doesn't prevent people from
Because
dying.
you know the trend in India, at least till recently, used to be that any COVID patient is ill, whether the D dimer is high or inflammatory markers are high, you put them very early on a low dose of, let's say, Clexane twice a day and cover up the hospital period, and then discharge them on NOAC for a couple of weeks' time. So what we get is that this may be a practice, but there is no clear proof, scientific proof or data to support what we are doing. And perhaps we should be careful and not doing it, isn't it?
Well, not only is there no clear proof, there is actually more evidence of harm than there is of benefit. Now, in the less sick patient, it may yet be beneficial. Maybe if we start very early, there could be benefit. My only caution is doctors treat patients and they must do what they think is right. But I would say have a healthy sense of skepticism about antithrombotic therapy in COVID, because there is absolutely no evidence that antithrombotic therapy works. I mean, zero evidence, zero randomized evidence. And there is now 3 trials have stopped early in ICU because of potential harm. So we need to be very cautious about adopting a therapy without evidence. Now, there are observational studies. There are certainly people who say, I know that if I treat my patient, they do well. I don't believe that. That's why we do randomized trials.
True. Many of our beliefs and many of what we see would be biased, and we see what we want to see, right?
Yeah.
And when we have trials which actually tell us, we start seeing it in a different light. Oh yeah, I never thought that this doesn't work. Yeah, I think.
Now I'm respectful of my colleagues. I know you have to do something, and if you do it, well, that's fine. Let's wait for the data. But remember the coronary care story, ventricular premature beats. We knew 30 years ago, if we gave lignocaine and procainamide and we suppressed these VPBs, we must save lives because they're bad, aren't they? And then we did the trial and we showed that we suppressed VPBs, but we killed patients. So
True. So everything doesn't work logically in medicine. We have about a minute or so. One last question. Many people often say that when we see a patient with a peripheral vascular disease, just a peripheral vascular disease, let's say asymptomatic, we pick it up in the outpatient. We always say that this patient has a very high chance of having a coronary artery disease, right?
yes.
So we teach our residents that the moment you see his peripheral pulses are not good, think that he might be having an abnormal coronary angiogram, right? So today, with the COMPASS data showing so much of benefit on PAD, would you recommend that the moment we diagnose in PAD, we should think in our mind of a combination of a low-dose Rivaroxaban with aspirin? Because we had always been teaching statins, we have been talking about clopidogrel, and maybe we were talking about cilostazol if the patient is symptomatic for peripheral arterial disease. Has that concept changed? And would you recommend that it's time that we shifted on to a Rivaroxaban aspirin combination?
It's an absolutely wonderful question. And I think we are one step short of routinely recommending it. But I think it's entirely reasonable because we know that asymptomatic PAD with an ABI of less than 0.9, 2 out of 3 such patients will have coronary disease and maybe even more. So they are certainly the highest risk people if they have coronary and peripheral artery disease. In COMPASS, we did do an ABI on all 27,000 people, and people who had coronary disease plus a low ABI without symptoms were very high risk. So the quick answer is, I think it's a very reasonable approach. It's not quite proven because we didn't specifically look at that, but I think it's very reasonable.
I think just that one last question, I can't stop myself from asking you because it's so interesting to know facts from you. I was reading the PESA trial, PESA, which was part of that atherosclerosis trial which came from Spain. They took about 4,000 patients of employees of the Santander Bank, asymptomatic, no cardiovascular disease, and did an MRI and an FDG PET. And they found that about 30% had asymptomatic subclinical polyvascular disease. And of them, they found 15%, roughly, had features of inflammation. I mean, atherosclerosis, you can say that, okay, you are growing older, you get atherosclerosis. But 15% had either cerebral or coronary or aortoiliac inflammation clearly by the PET FDG, which means that they have inflammation, they might be more prone to events. So if we really pick up a subclinical atherosclerosis, maybe by a carotid ultrasound or maybe by whatever, a 64-slice CT, and find that there's evidence of subclinical atherosclerosis, is it time that we recommend a dual pathway inhibition to these patients?
Well, again, a beautiful question. What we learned from the aspirin primary prevention story is that if we take patients today who are already treated on statins and we add aspirin for primary prevention, the benefits are very small. The higher the risk, the more likely aspirin is to benefit. I think it's going to be the same with Rivaroxaban plus aspirin. It's going to benefit people almost entirely across the board, but those at lowest risk are going to be the ones where the balance between risks and benefits is the most finely tuned. So your population that you describe, if you add atherosclerosis plus inflammation, they're up on that spectrum of risk. They're going up the chain. Now, if they also have diabetes, they go further up the chain. If they have any symptomatic disease, they go further up the chain. So where is that magic cutoff? I don't know where the magic cutoff is, but each of these elements alone may not be enough to treat. But when you add them up, you start to get the high-risk patient. And the beauty in COMPASS is you can identify a high-risk patient because they have multiple risk factors, or because they have polyvascular disease, or indeed if they're already on 5 or 6 medications. We've done all these analyses. We're about to publish the pharmacy study. But any which way you can evaluate their baseline risk, anything that identifies a high-risk patient also identifies a patient who will get large benefits of the COMPASS regimen. It's a wonderful question and really helping me to think through it. I think it's too early to treat all these bank employees with Rivaroxaban plus aspirin, but we need to think of the principle.
Yeah, we would agree on that maybe 5 years down the line.
Yeah.
So I think we are already past time. It's 8:35 in India. So please give us a take-home message for the Indian physician on what do you think would be something that we need to carry on for tomorrow morning's clinic, the kind of patient that I would see, pertaining to prescribing Rivaroxaban and aspirin combination vis-a-vis maybe a dual antiplatelet.
Well, I'd like to say the world has changed profoundly in many ways, but in the antithrombotic field has changed profoundly with the advent of DOACs. And today in 2021, in India and elsewhere in the world, you have an unprecedented potential to reduce morbidity and mortality due to thromboembolism. As you see your patient in the clinic tomorrow morning, you should think, vascular patient, can I further mitigate risk with low-dose Rivaroxaban? Because this therapy reduces morbidity and saves lives. The challenge to you, my colleagues and friends in India, the challenge to you is to use the tools at your disposal to optimally protect your patients against the suffering due to atherosclerotic vascular disease.
Thank you, Dr. John Eichelbaum. That was an excellent learning for the last 1 hour or so. We are passed by in excess of about 10 minutes. We're sorry about that, but we did learn a lot of things. It was so nice interacting. Can I ask Dr. Vishal now to take over and give us his concluding remarks? Dr. Vishal?
Yeah, thank you very much, Doctor. It was a wonderful session, and I'm sure that this is going to very, very positively impact the lives of a lot of patients, and that's what we go by, to patients, and that they should get the best. So it was wonderful, and Dr. Tiny Nair, thank you for a wonderful deliberation and moderation. We are very grateful, and it was our privilege to listen to both of you. I would also like to thank the audience for being with us and posing so many questions. So thank you very much. Thank you very much for joining this webinar.
Thanks very much.
Good night.
Bye-bye.
Good morning to you, Dr. John.
And everybody stay safe.